Again, thank you for joining us. I would now like to introduce our speakers. This evening, we have Dr. Kiron Thomas. Dr. Thomas graduated from Tufts University in Boston, where he achieved his board certification in neurology. He then completed his interventional neuroradiology fellowship at the Leahy Medical Center in Burlington, Massachusetts. He has lived in Bakersfield with his wife and children since 2013. We also have with us Dr. Sara Honari. Dr. Honari completed her undergraduate education at USC. She then graduated with high honors from the Ross University School of Medicine. Her education continued at Conemaugh Memorial Medical Center, where she was awarded Best Intern of the Year during her general surgery internship. After completing her surgical residency, she continued on to her vascular surgery fellowship program at Maimonides Medical Center in Brooklyn, New York. Upon completion, Dr. Honari made the decision to relocate to Bakersfield, California, and join the team at Kern Vascular, helping to meet the needs of our local community. So with that, I'm going to turn it over to Dr. Thomas. So I'm going to stop my screen. If Dr. Thomas can share your screen, please.
Good afternoon, good evening, and welcome everyone to this talk. Thank you so much for Dignity Health for arranging this. It's a pleasure to be here. And May is Stroke Month, so we thought it would be appropriate to have this discussion on stroke care in the community, in the hospital, and the advances in the treatment of stroke that we have achieved over the recent years. Many thanks for the kind introduction, Sean. And particular thanks to David. I don't know if he's still there, but unfortunately I'm on call, so I won't be able to partake of his libations. But good evening again. I'm Dr. Kiron Thomas. I'm a neurointerventionalist or interventional neuroradiologist. The specialty is also referred to as endovascular neurosurgery or neurointerventional surgery, sometimes interventional neurology and such. They all mean the same thing. It is essentially image-guided diagnosis and therapeutic interventions of the neuroaxis, the blood vessels that supply the brain and spinal cord. I am the Stroke and Neurointervention Service Director at Bakersfield Memorial Hospital. And today's topic is particularly geared towards addressing and explaining the programmatic approach to treatment of stroke. Stroke, historically the term is a clinical diagnosis. It's a syndromic diagnosis, just referring to the brain dysfunction that people develop with the problem. This was before the advent of newer imaging modalities, but in the more recent decades with the advent of advanced imaging technology, stroke is generally used to indicate a specific pathology from a vascular cause. It could be either hemorrhagic or ischemic. They're both equally important and equally devastating, can be. And today the talk is geared more towards ischemic stroke, how it presents, what it can do to people, and what we can do to prevent it, which is going to be the later part of the talk by Dr. Honari, who's kindly agreed to join us, and the treatment when you have it. So I'll just click on the left side. Okay, so we have a patient here. I believe, I know that we all have the appropriate authorizations to use her name and images here. She has kindly agreed to the same. Mrs. Freeborn is a 68-year-old woman who presented to the Bakersfield Memorial Hospital emergency room on September 8 with neurological symptoms. And her symptoms at that time was mild right-sided facial weakness and right-sided extremity weakness. She was also having a little bit of difficulty with articulation of words, but pretty much normal language otherwise. She came to the emergency room a few hours after the onset of symptoms. So that is point number one. And again, going back to the programmatic approach in treatment of stroke, it is very important because treatment of stroke is actually a continuum. It's not a one physician, one patient, or one department specific intervention or diagnosis. It starts from the point of recognition of the stroke. Maybe it starts even before that in trying to prevent the disease in the first place. But once you have the symptoms, recognition of symptoms is the most important phase or element in the treatment of stroke, because the sooner you recognize the symptoms and seek medical attention, the better chance you have at meaningful recovery after the devastating symptoms of stroke. Um, we have studies that have shown that with every minute, approximately 2 million neurons or nerve cells, brain cells, to be 1.7 odd million brain cells die every minute with ischemia. When there's a blood vessel that is blocked, with every minute that is used without restoration of blood flow, you have approximately 2 million brain cells that die. Fortunately, we have an abundance of brain cells, but again, not enough to account for 3 or 4 hours worth of continuous ischemia and damage to brain like that, unless you're okay with having devastating permanent deficits. So recognition of symptoms and all right, I hope everyone can hear me now. The computer just played a trick on this, but if for any reason you can't hear, let us know. So the treatment of recognition of symptoms and initiation of treatment timely is the most important phase. In her case, she recognized the symptoms but chose to ignore it. And that's one of the key features of ischemic stroke, because stroke is essentially a painless syndrome. It's a painless brain dysfunction. And pain is one of the most powerful motivators for people to seek medical attention. And because there is lack of pain here, they usually tend to ignore, bargain with themselves, hoping that it'll just go away on its own. Maybe they slept the wrong way, this or that. But soon they will realize that the symptoms are not getting any better. If anything, it's probably getting worse. So timely medical attention, timely initiation of treatment is key to reversing or halting the progression of symptoms and brain injury. And this patient, Mrs. Freeborn, unfortunately, it was a few hours before she decided to seek medical attention. It was only after she spoke with her daughter on the phone, who happened to be a registered nurse, that she agreed to come to the emergency room. And in the emergency room, she was determined to be not a candidate for intravenous therapy, which is the FDA-approved standard of care treatment for acute ischemic stroke. So patients who present within the first 3 or sometimes up to 4.5 hours of symptoms can be considered for this particular treatment. It's essentially a clot dissolving medicine called alteplase. These days, a newer medication is being discussed, but it's not yet a standard of care. At this point, we only have one FDA-approved agent or drug for treatment of acute ischemic stroke, which is alteplase. And Mrs. Freeborn was determined not to be a candidate for this intravenous thrombolytic therapy because she had presented after 3 or 4.5 hours of the initial symptoms. So she lost out on that count. But, as I said, treatment of stroke is a continuum. We don't stop there. She came to the emergency room. She was evaluated by the telestroke service, who beamed in within a few minutes of being alerted. So the delay was not on their side. It was actually the patient who was, for lack of a better phrase, responsible for the delay because she chose to wait on her symptoms rather than seek immediate medical attention. In the emergency room, after telestroke evaluation, who decided or determined that she's not a candidate for IV therapy, the ER doctors started what we call the stroke workup and management. Hyperacute treatment of stroke. So within the first few minutes or hours of the symptoms onset, the key feature, the key phase is trying to find out what's caused the stroke, what vessel is occluded. Again, we are referring to ischemic strokes here. And is there any way in limiting the progression of ischemic injury? And how can we achieve that? Well, if it's a small vessel, the injury is probably already done. And if she's not a candidate for intravenous thrombolytic therapy, then there's not much we can do for it. We stop there and we go on to the next phase, which is acute and subacute care of the patient. But if it's a large vessel, you could argue that, okay, the core injury is already done, okay? But there may be a substantial amount of brain that is still being threatened of ischemia, but not injured or infarcted yet. So that is where the role of endovascular reperfusion therapy begins. Mrs. Freeborn came to the hospital, determined to be not a candidate for IV therapy, then considered for endovascular therapy. And again, the criteria or the primary indication for endovascular reperfusion therapy is again pathology. They have to have a large vessel occlusion. In her case, we knew that her left middle cerebral artery was completely occluded. And this is from an angiogram that was done at the time of initial evaluation. This is a CT angiogram, non-invasive, involves giving the patient contrast dye, which will go into the blood vessels supplying the brain, and will give us a nice picture. This is a three-dimensional reconstruction of the cerebral and cervical blood vessels. And we can see, if you can follow my cursor, you have the aorta here and the great cephalic vessels going up the neck. This is the right common carotid, left common carotid. You see that it divides into two, one that goes to the face and the scalp, and the major one that goes to the brain, called the internal carotid artery on the right side. You can see a little bit of irregularity at the origin, and but nothing terrible at this point, at least on this imaging. On the other hand, the left common carotid artery goes up. It divides into the one that goes to the face and the scalp, but the branch that goes to the brain is completely missing from the origin. You can see that there's a hard stop here after a stump. And you don't see the vessel at all in the cervical course or in the proximal intracranial course. Inside the brain, actually at the base of the brain, you can see the left middle cerebral artery does opacify, just like the right middle cerebral artery. And so does the anterior cerebral arteries on both sides. And how is that possible if the left ICA is occluded? It is from collateral flow, likely from the anterior communicating artery, which is a little connection between the left and the right in the front. And that is opacifying, even though you don't see the connection. It's probably a small vessel, and it's actually filling the left MCARK. So a patient with minimal or mild symptoms, which was her case, minimal aphasia, and a very, very slight facial droop and weakness. She looked very stable. The symptoms were not progressing. You know, the question was asked, is there any role for endovascular reperfusion? Which means if we were to consider that, I would have to go through the common, and get a wire or catheter through this occluded segment to open it up and maybe put a stent in to open the vessel up. But during that intervention, during that instrumentation of the vessel, there's always a risk that you can actually flip a clot or a plaque from here, which can then travel all the way up here and occlude the intracranial vessel or branch, which is now patent. So you could actually end up doing more harm than benefit. For that reason, because of her clinical stability, we decided we can leave this alone. She's probably going to stabilize hemodynamically and neurologically. We'll leave this alone, and we'll put her on a medication like aspirin or Plavix, or maybe even heparin for the short term. We admitted her to the neurointensive care unit. Now, that is another element in the programmatic approach to treatment of acute stroke, is the neuro ICU. And why is that important? Because of the expertise that we have in terms of nursing staff and physicians, and also the continuity of care. So we have people who are monitoring the patients on a dynamic basis, 24/7. And what are we doing? We're essentially looking for clinical symptoms or signs of worsening of the brain perfusion. So you cannot obtain a CT cerebral perfusion every hour or every 30 minutes to assess, hey, is the perfusion any worse than it was an hour ago? All we can rely on is clinical examination. And it's a fairly good indicator. And this patient came in there, was found to be very stable, and was monitored closely. Early next morning, almost 14 hours later, she started declining. Her speech and language got much worse. She became, there was a lot of paucity of her spontaneous speech. She was not talking that well. And even when she started or attempted to talk, she was making a lot of mistakes, jumble speech, and, paraphasia, which is using, non-existent words for that matter. And on top of that, she also started getting weak on the right side, or weaker on the right side. So this is the brain telling us that, okay, so far I was just hanging in there because there was barely enough flow, but now there is further compromise of flow or whatever it is, and I cannot withstand this anymore. So at that point, we decided to do a cerebral perfusion, okay? Now, the reason why we did the cerebral perfusion is to find out, hey, is the occluded left ICA really significant? Meaning, is that the little variation in our clinical symptoms or deficits is just because, there's the expected evolution of the infarct, or is there more brain territory being threatened of infarction? And perfusion study, the CT cerebral perfusion, is an imaging modality that essentially a variation of a CAT scan that employs contrast administration. It'll tell us how well the brain cells are bathed in blood as opposed to the contralateral, the opposite normal side or supposedly normal side. And you can see that these are different color maps of the imaging of the different CT perfusion parameters. There are three main parameters that we're looking for. One is cerebral blood flow and cerebral blood volume and mean transit time. And what it does is differentiate between uninfarcted or normally perfusing brain to underperfused or ischemic penumbra, which means a brain territory that's getting some flow but not enough, and it's a threat of further infarction. And three, core infarct, meaning irreversible injury that's already occurred. And you can see that the cerebral blood volume is fairly symmetric between the two hemispheres. On the other hand, the cerebral blood flow is bluer on this one compared to the red. So blue means ischemia, less blood. Red means good, happy brain. And this is underperfused, or the cerebral blood flow is reduced on the left side. And on the cerebral mean transit time, meaning the time that the contrast, a bolus of contrast, will take to traverse the arterial system and get into the veins, you can see the transit period is prolonged. So red is increased, blue is decreased. You can see that the mean transit time is prolonged, meaning the flow through the entire system is quite delayed compared to the right. So now we have two parameters. One is clinical indication. She's not doing well. She was doing well a few hours ago, and now all of a sudden she has started tanking. So that is the brain telling us direct indicator of low perfusion. And then we have a CT perfusion study, which is a more objective. Again, this is not absolute, but more objective way of determining the blood flow pattern within the brain. So we took her to the endovascular suite at that time. To remember, this was more than 12 or 14 hours after the onset of initial symptoms. And before we went to the left side, I decided to inject the right side to see one of two things. One, how bad is the stenosis in the neck on the right side? And two, how well does the left side perfuse or is vascularized with collateral flow from the right? So you can see this is a coronal view, meaning head-on view, and the second one is a sagittal view, looking from the side. My catheter is in the right common carotid artery. I'm injecting contrast, which is the darkness, the blackness that we see. And you can see irregularity of the carotid bifurcation. On the sagittal view, which delineates it better, you can see it is at least moderate and appears probably moderately severe. And you can see the white patch there that you see is all calcium. So whenever there's calcium, you cannot accurately estimate the degree of stenosis. That's why I said it looks probably moderate, but it's actually probably moderately severe or even severe stenosis. And intracranial view, the same vessel injecting the right common, you can see that it vascularizes the right anterior circulation very well. And this is the early arterial phase. This is the late arterial phase. You can see that there is only a wisp of flow through this segment of the anterior cerebral artery on the left. And for that reason, there's not much flow to the left middle cerebral artery, which could mean one of two things. One, maybe a clot flicked off from the occluded cervical segment, and now it's blocking the entire terminus of the left ICA. That is why you're not seeing any flow through this segment. Or this was always underperfused because this vessel was never good enough to supply this territory by collateral flow. What we saw was just collateral filling from the anterior cerebral artery. You can see that it is slowly coming over to the left MCA territory here. Again, another indicator of cerebral underperfusion. And we checked the vertebral artery too to see if there is any collateral from the vertebral artery, which again, you don't see anything coming to the anterior circulation at all. The vertebral artery and the basilar system is just perfusing the posterior circulation area, which is the brainstem and the cerebellum and the occipital lobes. Nothing goes to the anterior circulation. So the brain cannot depend on the vertebral basilar circulation either. Now coming to the culprit vessel, the catheter is now in the left common carotid artery. You can see nice, robust um, left external carotid artery and its branches, which goes to the face and the scalp. But the internal carotid artery, after a little irregularity there and a stump, it is completely occluded. There's no flow through the cervical segment at all. So normally the dictum is if the vessel is completely occluded, don't open it, because again, it is more harm than benefit to open up a vessel that's occluded. That used to be the dictum before, but now there's a paradigm change, because what now matters is there salvageable brain? That's the only thing that we look for. We don't look at the actual time of onset of symptoms for determination of endovascular therapy. We look at the size of the core infarct, the irreversible injury or infarct, and amount of salvageable brain. If we think that there's a fair amount of salvageable brain that will make a clinical difference to this patient's long-term outcome, we go ahead and try reperfusion. So this vessel, which is completely occluded here, we thought it'd be a reasonable risk to go in and open it up, knowing that during that process, you can result in vascular injury like perforation and bleeding. You can result in further embolization from whatever junk is occluding this vessel. That embolus or emboli may actually travel up and go occlude the vessel, which was previously known to be open. So what did we do? We went in there with a set of wires and catheters and everything, but long story short, we left a stent in there in the occluded segment of the left cervical internal carotid artery. Now the vessel is completely occluded in the completely open in the cervical segment. As you can see, it is filling up nicely up to the supraclinoid segment inside the skull. You cannot see any further from there because it's outside the field of view. So going to the next slide, I'm taking intracranial shots. You can see the left ICA goes up, divides into the anterior cerebral artery, perfusing nicely, and the middle cerebral artery, which is patent up to the bifurcation. This is the M1 segment of the left middle cerebral artery. And here there should have been two major branches. And you can see that it is occluded. It's completely occluded. And this would explain why the patient got symptomatic later on during the admission. What possibly happened was a little embolus flipped off from the occluded cervical segment and caused the occlusion there, giving rise to more profound deficits. So now attention is diverted to opening up this vessel, because that's ultimately what will determine the outcome of the patient or reperfusion. So at that point, these are more magnified views. We get a wire all the way through the occlusive segment, and we deliver a device called a stent retriever. And you can see the silhouette of that device here, these markers, that is the device. And this is an unsubtracted view. This is a subtracted image, meaning the skull has been subtracted out of the image by taking two images and superimposing them on each other. And you can now see the device. These are the markers on the device that's been left within the presumed occlusive segment. And the idea is to pull the clot out, whatever is occluding the vessel, to try to suck it out. This is what the device looks like in real life. The stent retriever is shaped like a stent. The only thing is it's attached to a delivery wire and it's non-deployable. You cannot detach it just like you would do with a stent, because the purpose of normal stents is different. It is to open up a vessel that's blocked. The purpose of a stent retriever is to retrieve an occlusive embolus, which is usually a clot. For that reason, there's no reason to leave the stent there. It is retrieved out with presumably the clot. And this is a picturization of a device within the vessel itself. So if the clot is here, I don't know how clear this image is for you guys, but there's a clot that extends from here to here. You go and deploy the device within the clot and give it some time, about 5 minutes or so, allowing the struts of the stent or the device to sink into the clot and trap it. And then you slowly retrieve it out. And once you pull it out, hopefully the clot will come with it. The success rate is about 90 to 95%. And you can see we have opened up the vessel now. This is the left MCA, which was previously occluded at this level. Now it is open. There is a good anterior temporal branch, and there's the inferior division. There's the superior division. There's a vessel that's occluded here already. It is still persistently occluded, a small branch, and maybe occluded here too. Now, we don't go after, the idea is not to make a pretty picture. The idea is to, salvage brain that is not infarcted yet. If you have an occlusion here or occlusion this distal, chances are that injury, that brain is already infarcted. It is not salvageable. The reason is normal brain tissue, if there's complete lack of blood flow, complete ischemia or anoxia, it cannot survive that for more than a few minutes. 8 to 10 minutes, it leaves a permanent injury. So for a terminal vessel like this, the chances of that brain being salvageable is very low. And also these become very risky because when you open up these vessels or try to open up these vessels, the risk of hemorrhagic transformation is very high. So that is her radiographic story. Patient comes in, determined to be not a candidate for intravenous thrombolytic therapy because of time frame, determined to be not a candidate for endovascular reperfusion therapy at that time because we thought she didn't need it. She has already stabilized. That didn't turn out to be the story. A few hours later, she declines. We find the occlusion in the neck, stent it open, find the occlusion inside the skull, inside the brain. We suck the clot out and open it and reperfuse in the brain. So what happened? She did have, not so small ischemic strokes because during all this, which probably took like 3-4 hours from the time of recognition of her decline, getting the appropriate test, getting inside her vessels, opening it up and everything, it was a good 2-3 hours at least. And during that time, you have to remember that, there is ongoing ischemia and injury. And so she did have a not so small infarct and she did have fairly significant deficits at that time. But long-term outcome, in 3 months or 6 months after the event, her modified ranking score, which is a functional scale to determine how well the patients are doing in terms of independence and capacity to carry on with normal living, she was on the MRS score, the modified ranking score, she was a 0 to 1, meaning she was doing pretty much everything that she did before, maybe minimal disability, but not requiring any assistance. So this was a successful, a happy ending story. It's not always the case. We know that from our personal experience, the chance of being able to help someone regain their pre-morbid condition is about 50%. So for every 2 patients or every 10 patients that we treat, we are able to help about half that population. Now, in the past, that used to be terrible. And even, so you could argue that, okay, only 1 out of the 2 will have a better outcome. What happens to the other? Well, that is how devastating the condition is. That's just, highlights the importance of this condition, how devastating the clinical pathology can be, and what how important it is to seek timely attention at the appropriate center that's capable of delivering such care. At this point, I'll turn over the screen to Dr. Honari, a vascular surgeon, a great asset to our program, because as I said, this programmatic care. It starts with the patient family and the patient himself or herself recognizing the symptoms. The EMS bringing the patient to the appropriate center. The ER physicians and telestroke services, if applicable, for timely recognition and institution of therapy. The endovascular providers to take care of the reperfusion interventions, if applicable. Neurointensive care unit to provide close neurological monitoring and critical interventions as needed, and vascular surgery for both the preventative measures that she's going to explain later on. But sometimes there are lesions that are not stentable, then they may need open surgery. There are other interventions like complex neurosurgical procedures like cerebrovascular bypass and all. That's a little bit outside the scope of this discussion. But again, as I said, it is not a one-shop, one-step in the treatment of acute stroke. It's a continuum of care where a lot of programs, a lot of specialties and departments are involved. And fortunately, we have a center here in the community, in the city, that's able to deliver all that. So I'll turn over the screen to Dr. Honari. Thank you so much.
Thank you, Dr. Thomas, and thank you everybody for joining us this evening. So we shared the same patient, Ms. Reborn. So after she underwent stenting by Dr. Thomas due to her left hemispheric CVA, she had a CT on follow-up with him. And if you remember earlier during her original CT angiogram in the hospital, on the right side, they were noting 70% stenosis. This new CTA actually was read as only 50 to 69% stenosis. However, on further review, it's very obvious the vessel appeared critically narrow at the origin. Dr. Thomas sent her to see me. At that time, I did a carotid duplex, an ultrasound of her neck, and at that I noted that she had systolic velocity of 269 in the internal carotid on the right side, which is indicative of a greater than 70% stenosis. So she was with her daughter, and we had a discussion of that she is at increased risk of stroke on the right side at this point. And based on the recommendations, we would say that she should proceed with elective surgery to prevent a future large stroke. And she agreed. So she underwent a carotid endarterectomy. It's an open surgery, unlike the stent. Patients under general anesthesia. They go to the ICU afterwards for close monitoring, and they usually go home the next day. They have a small incision on their neck along their sternocleidomastoid, and all the stitches are usually under the skin. You can barely tell that the incision was there approximately 2 weeks later. So she did well. She went home. She continues on her medications to reduce the recurrence, the buildup of the atherosclerosis in her arteries. And she continues to follow with me for interval surveillance of ultrasounds to make sure that the atherosclerosis doesn't build up to severe stenosis again. So a little bit about carotid stenosis. We all know that secondary stroke prevention is important, and knowing who's at risk is important. There's controllable risk factors that we as physicians can help with. High blood pressure being one of the most common causes of ischemic stroke, as well as smoking with any kind of vascular pathology, diabetes, patient's diet, their physical inactivity, which goes along with obesity, as well as high cholesterol. Other patients that are at high risk but have risk factors but not within control is patients' age, family history, race, their gender, males being more predominant, and prior stroke or TIA or coronary artery disease, or having actually MIs in the past. So at this point, so do we actually take this high risk group of patients and screen them? It's actually currently recommended that we do not do that, at least not for the general population. However, if patients have any TIAs in the past or have had any stroke or any neurological signs or symptoms in the past, they should undergo imaging, which is initially done with a carotid duplex and ultrasound of the neck. And if stenosis is noted at that point, if it's not significant and they're still asymptomatic, then it's still recommended that they have surveillance over every 12 months to make sure that the stenosis doesn't become severe. Now, our recommendations are currently based on actually studies from the 90s, specifically the ACAS trial, the asymptomatic carotid artery study, which obviously deal with the asymptomatic patients, as well as the asymptomatic carotid surgery trial. And these two trials, both done in the 1990s, basically the ACAS, which is the most known, it took patients who had carotid artery stenosis greater than 60% for stroke prevention. That's took randomized patients, and it showed that the surgery halted the relative risk of stroke by a significant rate. It was actually so significant that at that time they halted the study approximately a little over 2.5 years into it, because they saw that it was such a significant difference between the patients who were assessed with medical management versus the ones that underwent surgery when they had greater than 60% stenosis. The medical therapy, though, in this study, so the two limbs of the study was surgery versus medical management, and the medical management at that point was not up to the current standards that we have right now. It was not a requirement in that study for the patients to have any lipid-lowering treatment, and only a minority of the patients actually did have it. In addition, our blood pressure standards back in the 90s was much higher than it is at this point. So based on that, at this point, we've said that current medical management is for patients with asymptomatic stenosis, less than 60%. We actually watch it a little bit more clinically, and sometimes we wait till about 70% for surgical management of these patients. Now, what do we do with the medical management is obviously we place them on high dose statins. They need to be on antiplatelet medications, normally just aspirin. and their hypertension and diabetes has to be very well controlled, as well as lifestyle modifications, such as smoking, exercise, loss of weight. And then if they do have severe stenosis, or they become symptomatic and they are noted to have greater than 50% stenosis, at that point we want to intervene. And that is done either with a carotid endarterectomy, open surgical, or carotid stenting. And it summarizes my side of the presentation. I'll send it back to you, Sean.
All right, thank you, Dr. Honari. I'm sorry there was a delay in the transition. Thank you both. Great presentations and very valuable content. I don't see any questions in the chat. Is there anybody in our provider community here that's joined that has a question?
Yeah, this is Dr. Bengu. I have a question. I'm an internist. So I would like to know, so sometimes we screen patients for something else. Turns out to be there's an issue with the carotid artery stenosis. Is there a percentage number that you can give us? I heard Dr. Honari saying 50%. Is that when you get a little concerned, or how do you follow a patient?
So with the duplex, it gives you a range. So anything less than 50% we usually don't worry about, but 50 to 69% is when you want to start screening the patient more often or surveying the patient. If they do have any stenosis and they have risk factors after having to get having had a duplex, it's very reasonable to get another duplex yearly to evaluate that, but also very important to modify the risk factors that are modifiable. But at about 50%, we only intervene surgically if they're symptomatic. Anything over 69%, basically, that's when we would consider intervening when they're asymptomatic electively.
Thank you. I have a follow-up question. Sometimes, this estimate is given, that's 55%, let's assume that. And then just like an echocardiogram, then you do another one, instead of 55, they come down to 50 or go on to 69. Is that a little bit of a operator induced? What I question will be that if I see a patient with something like 52%, should I do another carotid ultrasound, Doppler, maybe a little bit sooner, in a month or two, to make sure that number that I give it to the patient, as well as a follow-up type thing, is a real right number, or you don't see that variation?
Yeah, just like with echo, ultrasound is tech dependent.
Yeah.
That's why having a registered vascular technician doing the ultrasound is very important. Looking at the velocities that are actually shown in the imaging to dictate whether that stenosis is there. But normally the ultrasound can't give a specific stenosis because we've correlated velocities to certain ranges. So it's usually the ranges that are known and validated are either less than 50%, 50 to 69%, 70 to 90%, or occlusion. So if there's a specific number that's given, it's usually not a very valid ultrasound because you can't take a specific velocity and correlate it. And so if there is concern and there has been discrepancy between studies, which has happened, the next step would be a CT angiogram, or if the CT angiogram has discrepancy, then a interventional angiogram.
Thank you.
This is Dr. Bowie. Can you guys hear me?
Yes, Dr. B.
Oh, hi, this is Dr. Bowie, a vascular surgeon. Great case, by the way. But I have some questions because in terms of management of the complete occluded left ICA, normally with vascular surgery, when we were traditionally taught that if it's completely occluded, we usually, what's done is already done. We leave that alone, because when we revascularized, open up an occluded carotid, you may make things worse. And so this revascularization was successful. It's great, but do you think the stenosis on the right side was critical, and whether when she turns sour, what about medical management in terms of increasing the blood pressure or treating the right side?
Yes, I believe that's a question for me. So I'll answer this. So yes, Dr. Bui, very valid concerns. There's been the dictum and there's still the dictum. If it's completely occluded and the patient is clinically stable in terms of not just normalcy, in terms of deficits too. So sometimes the stroke has already occurred and the patient has deficits from that. And if the deficits do not increase, we will consider that patient has to be clinically stable despite having deficits. So if their patients are stable and the vessel is completely occluded, we do not revascularize. That would be the answer. And the second part of the question, that's particularly why I went to check the right side out to see if that is either critical stenosis or if just opening up that vessel maybe increase the flow to the contralateral side and avoid having to instrument the left carotid. That's why I checked the right side out. Two things. One, on the angiogram, the calcification, after accounting for the calcifications, looked like maybe moderate, maybe severe, but who knows. But more importantly, the A1 segment of the left anterior cerebral artery appeared hypoplastic. It was either occluded or hypoplastic. So no matter what you do in terms of increasing the pressure, the flow through the right-sided system, it is not going to pass on to the left side because the A1 segment of the left anterior cerebral artery, despite having a patent anterior communicating artery, is not going to be helpful. So the third point is in the neuro ICU, that's one thing that we pay particular attention to for people with hemodynamic instability or conditions that look like potential instability, like occlusions. We keep them on a relative hypertension. So up to 200, we don't even treat that. And her blood pressure at that time was around 200. So she had symptoms despite maximal medical therapy. She was on heparin. And despite that, it looks like she threw a clot up there. And two, she did not have a healthy or robust collateral circulation to the left side. So opening up the right side would not have served any purpose. After all that is said, again, revascularizing an occluded vessel absolutely does carry a risk of hemorrhagic transformation, causing more embolization to the territory. It's all there. But without that, the outcome is going to be a large hemispheric stroke because she was already showing that. After a period of relative stability, she started declining slowly. And again, this was not a stepwise decline. This was progressive decline, meaning that over time, there was more and more evidence of clinical and radiographic evidence of deterioration of brain function. So taking all those things into account, we determined that she's a candidate for revascularization. Normally, we don't offer it beyond 6 hours or 8 hours at the most for anterior circulation. But in her case, she was relatively young, and we thought it was appropriate to do something. And ultimately, it ended up being a happy story, as you said. Again, it's about 50% most of the time. It is the revascularization is easy, which was in her case. Sometimes not that easy, especially with an organized clot. And two, clinical outcome does not correlate with the angiographic outcome. You can have beautiful vessels, but the infarct is already done. It's about 50% the chance of improving the long-term neurological outcome for a patient. Hope that answers your question.
No, thanks a lot. And it looked like she had a great outcome.
Yeah.
Okay, we do have a few questions in chat. Let me see. This one is FFR an option for cerebral arteries? Whoever would like to take that?
If you could, can you hear me? Okay. If you can just tell me what FFR is. I'm not good with abbreviation, sorry.
So fractional flow reserve. So they use FFR in coronaries and they use them in peripheral. And I'm just wondering if there's any options or has there been any advancements to also include that with cerebral arteries?
Yes, so the assessment to see if the stenosis are valid, if the stenosis are significant, we know they're symptomatic because the patient are getting worse. But if it's significant, to determine the need for revascularization, it may have a role. It is not done primarily because these require special catheters with probes at the end, and we generally would hesitate to put anything especially in cerebral arteries, if the occlusion is M1 or anywhere beyond, we generally hesitate from putting any instruments because, as you know, these are extremely delicate. The chance of vascular injury is very high. And two, the dynamics, the intracranial dynamics is really different from the extracranial vasculature. So what looks like, very significant stenosis, for example, I saw an M1 stenosis today that looked like severely critical, like, barely a flow through a stenotic lesion, but the patient is doing just fine. And those patients, we should never revascularize them, no matter, even if they have a TIA, we just leave them alone because the chance of causing instrumentation-related injury to the vessel is much higher than any potential benefit. So for those reasons, estimating the flow reserve is not that useful. In fact, there are other modalities that we can use, but we usually don't have the time to do all these things in the acute phase of a stroke. One of them is actually looking at the cerebral flow reserve with a SPECT scan, a diamox SPECT scan. What it does is, you take a normal perfusion imaging, and then you inject diamox, which vasodilates, and look for any residual vasodilation after diamox. If there is no residual vasodilation in an occluded or stenotic vessel, what that means is that the vessels are already maximally dilated, and it does not have any further room for dilation despite the diamox. So those patients may benefit from revascularization. But the instrument-related FFR estimation, we don't do that in cerebral dynamics.
Okay, I have another question here. It says, what type of post-procedural management should be done in the PCP office?
Long-term care, long-term secondary prevention. Again, two things. One is the rehabilitation phase of the stroke that's already occurred. It does not stop in the rehab center. It's a continuum again. The recovery after stroke is usually in the order of weeks or months, and not days or hours. And so rehabilitation, therapy, physical, cognitive, occupational, speech, all forms of therapy, even vision rehab for people who have vision deficits from a stroke. So that is one phase. The other phase is secondary prevention, which Dr. Honari mentioned. Secondary prevention in terms of treating the definitive risk factors like atrial fibrillation or carotid stenosis, things like that. And two, primary vascular risk factors modification. So these are the two main aspects of longer-term care in acute stroke.
Okay, thank you. We have another question for either provider. It says, how does family history play a role in the risk of stroke? And is that at the parental level, or does it go back even further?
Family history has been proven to be a higher risk if it's a first-degree relative under the age of 65 that's had a stroke. So that's how they've done studies on that, makes the patient a higher risk factor for stroke.
Okay. Do we have any other questions from the providers on the call?
Dr. Thomas, I have a question. If this is Bengu again. So if a patient calls me and says, somebody, their mom has a couple of minutes of aphasia or couldn't move her arm and has risk factors and calls into an office as an outpatient, what do you suggest? That bring them to the office, try to check it, they have recovered? Or is it better to send them to the ER immediately to do some evaluation to see where they are on their spectrum? What would you suggest?
Yeah, to emphasize just the significance of this situation, I would say the phone call should not last even 20 seconds. The patient should just call 911 and go to the emergency room, because a TIA, symptom that is completely resolved, is the best substrate that you can work on to prevent the actual stroke. Because most of the time, as I said before, even with endovascular reperfusion therapy with large vessel occlusions, the best scenario is about 50%. The other 50% have a terrible outcome. For that reason, a TIA should be considered more important and more intervenable than a stroke itself. So if the symptoms have resolved, again, the nearest emergency room, unless, you can see the patient yourself within the next, as quickly as the patient will be able to see see a physician in the emergency room. It may be a reasonable thing, but you cannot take that as an algorithm, right? Because most of the time, providers in our office or your office won't be able to see a patient as quickly as an emergency room physician can. So for that reason, the dictum should be go to the emergency room.
In a follow-up question, like in cardiology, we immediately tell patient to take an aspirin or take actually 4 aspirins or even Plavix or something like that. Should
Yeah.
I tell the patient to do something like that or not do it, reach the?
No. Again, it's a fairly clear. The reason is, unlike cardiac pathology, where most of the time it's either ischemia or arrhythmia, brain, a significant portion, about 20 to 25%, is actually hemorrhagic and would present just the same way, except for maybe a little bit of variation here and there, and which may not be even recognizable by by the lay, by public. For that reason, antithrombotic therapy should not be recommended for focal neurological symptoms unless a brain bleed has been ruled out.
Thank you.
Okay, any other questions? Okay. Well, again, I want to thank our specialists for providing such valuable information. And from all of us at Dignity Health and the providers organizations, thank you so much for joining us. If you have further questions, I know you can see the numbers on here, but if you have further questions, please reach out to the Bakersfield Memorial Hospital Neuroscience Institute at 632-7126. This concludes our event this evening. Thank you for joining and spending your time with us. And we will stop our recording. This recorded presentation will also be sent out to everyone who registered. Thank you and have a great evening.
Thank you.
Thank you. Good night.